everyone. I think I've met you all now, but for those of you that I haven't, my name is Olivia and I am one of the new interns. And today I will be talking about prescribing opioids for post-operative patients on discharge. So opioids are quite a hot topic at the moment, and it's a concern for us because opioid prescribing in Australia has been increasing. Oxycodone can be used for end of use for its euphoric effect. The number of deaths from oxycodone and other pharmaceutical opioids actually outnumbers overdose deaths from heroin and cocaine use. I thought it was quite an alarming statistic. It's one of the most commonly diverted prescriptions in Australia and worldwide, and its misuse can lead to tolerance and dependence. And just on that point, misuse can be intentional and unintentional, and it can also happen in patients with no prior history to dependence or any drug-related issues, so it can happen to anyone. And there's a lot of evidence out there to suggest that there is excessive opioid prescribing on discharge, which could be leading to these things. So we'll be talking about opioid management in acute pain settings. So acute pain is pain that lasts for a short period of time. It's sudden in onset. For our patients, it has a cause, so for post-op patients, and it's expected that the pain will resolve. Acute pain also responds very well to analgesia. So when we're treating acute pain, what is our aim of treatment? So we want to relieve pain, assist rehabilitation in our patients, reduce hospital stay. We want to reduce or prevent that transition to chronic pain, and we also want to prevent or reduce any psychological or physiological harms that can occur. So what do we need to consider in our patients with pain? We need to consider them, all the things that we do in our normal practice, including their pain score and the clinical context as well. So monitoring requirements, staffing, do we have the medication? Once we've taken all those things into consideration, how are we going to treat our patients and what are we going to give them? So this is the opioid ladder that I'm sure we've all seen from the therapeutic guidelines. And at Austin Health, we have sort of extrapolated our own that we use. So we use this table, given the patient's pain score, we use a corresponding step on the ladder. So the main principles of this are we're always using non-pharmacological measures as our step one, then adding on paracetamol. If we need to step up to step two, we can use our adjuvant therapies like NSAIDs, pregabalin, and a mild opioid, and then stepping up again to oral or subcut or IV stronger opioids. With this ladder in an acute pain setting, especially for post-op patients, if we're going up that ladder, we're coming down very quickly. So we need to have someone reviewing all the time to make sure that we're stepping down, because we do expect the pain will resolve. And this just reiterates those principles, always non-pharm. If the analgesia is required, starting at a point at the ladder that corresponds to the patient's pain, so making it very patient-centred. Always start at the lowest dose and then titrate upwards. So that's just a bit about how to manage acute pain. So now that our patients are ready to go home, what are we going to give them? And this guideline has been developed to help us decide how much opioids that should be prescribed. This here is just an extrapolation of that's been edited and revised, and it will be being distributed to the surgical wards shortly. Livy's been working on that. So in this guideline, it goes through some more patient considerations. So what are we thinking when they're going home now? So that recovery pathway, so we expect acute pain is going to recover. What does that mean for our patient? What do we expect for them? And any need for rehabilitation? We also need to know their past 24-hour analgesia usage, and just the other points of what we've gone through and what we do in our clinical practice anyway. So looking at their age, renal function, hepatic function, any medications beforehand, do they have any pre-existing chronic pain issues, and is there any risk for misuse or unnecessary prolonged use? Then what are we going to give our patients? This is our little triangle so we've got our base here and then we work our way up. So paracetamol and our non-pharmacological measures, so an example would be 1 gram 4 times a day regularly, and and there are some patient groups where we would reduce, so like our elderly patients or our malnourished patients. And then we can consider stepping up if they require it, so something like our NSAIDs. On post-op, we would assume, again, because the pain is going to recover, only a maximum of 7 days treatment. So an example could be ibuprofen 400 milligrams TDS. And we might also consider celecoxib or even a weak opioid like tramadol. And then again, stepping up to our oxycodone immediate release formulations. A typical script might be something like 5 milligrams every 4 to 6 hours when they need it. And then again, stepping up to our slow release opioids. So we have Targin. So a typical discharge strength might be 5 to 10 milligrams. And we need a clear plan for weaning. So again, it's the acute pain. We don't expect it to last long, so we don't want them on a slow release opioid for very long. So usually a maximum of 7 days treatment. And then stepping up once again to our tapentadol. Again, same 7 days treatment. We don't want it to be going on for a long time. So if our patient is going home with oxycodone, how much do we give them? So that's where the 24-hour past opioid requirement comes in. So for instance, in the past 24 hours, if your patient's only used 10 milligrams, would only be needing to give them 5 tablets of the 5 milligram immediate release, which equates to 25 milligrams in total. I'm pointing on the wrong screen. That one there. If your patient's using more than 90 milligrams in the past 24 hours, it might not be necessary, it might not be appropriate for them to go home at that stage, and that they should have a review with APS for ongoing pain management. Now looking at this guideline, for me, I thought acute pain, why are we including slow release preparations in our guidelines if we expect that it will only be for a short period of time? And I know at uni we learnt that not to initiate someone on slow release preparation in an acute pain setting. So I looked into the ENSCA statement, which is the Australian and New Zealand College of Anaesthetists. And their statement on it is slow release preparations in acute pain settings are not recommended, but they do also acknowledge that in some patients they might have prolonged pain states and they might have high opioid requirements, and for those patients it may be necessary to transition their immediate release preparations to long-acting preparations on a temporary basis. So I think the key word is there that it's temporary, and we need to be making sure that we have a clear plan to wean down in these patients. So just a bit more on the slow release preparations and what we've included in our guidelines and why. So Stephen Shung is considered one of Australia's sort of pain management gurus, and he was involved in a similar guideline that was developed for the Royal Perth Hospital, where they too, for slow release preparations, acknowledge that some patients may require it if they have ongoing high opioid needs. Their first line is tapentadol, ours is tramadol, but we also include tapentadol as well as a step-up. They've also included slow release tramadol in the buprenorphine patches. From my understanding, we didn't include the buprenorphine patches in our setting because it's a bit too difficult to manage. So the community that they have, Stephen has a very close relationship with the GPs, does a lot of education for them, and they're able to step the patients down off it. But in a setting, such a big hospital like the Austin, it's a bit difficult to step down those patients on buprenorphine patches and liaise with the GPs to make sure that it doesn't get used on a chronic basis. So we've included tapentadol. So tapentadol is growing in popularity. So it is considered an atypical opioid. So it has new opioid receptor activity, but it also has no adrenaline reuptake inhibition activity as well. So there's been a few studies comparing it to other opioids, and it has improved tolerability, lower potential for drug-drug interactions or accumulation in impaired renal or hepatic function when compared with oxycodone. And it also has reduced toxicity and potential for abuse and misuse compared with other opioids. Another little fun fact I thought with this is that it has 18 times less affinity for new opioid receptors when compared to morphine, but only 2 to 3 times less potent. So that's sort of growing in popularity and use, but all of the studies sort of have a bit of a blurb that it needs to be compared with different formulations before they can make a clear judgment about it. pentothal use. So just going back to our guideline, there's also a big focus on education. So everything that we're normally doing anyway, label 1, label 18, with our oxycodone, but also a big focus on expected duration of treatment. So letting our patients know that we don't expect that the pain will be continuing, we expect it to resolve, and what to do if they are having continued pain states and how to get more medication. So Tim spoke the other week as well that communication is such a big key in this area. So communicating with the GPs, letting them know the opioid we're using, frequency, duration of treatment, and a clear weaning plan. And as Tim said, they're working on a guideline at the moment to help transition that care into the community a bit better. So just comparing our guideline to what's happening around Australia, this is the guideline that Stephen Shum was involved in. Very similar to ours, regular paracetamol. They only prescribe celecoxib and small amounts of tramadol if it's been initiated as an inpatient though. Very similar with their oxycodone, so they're using the past 24 to 48 hour opioid requirement to base how many tablets they give. And they too recognise that in some patients slow release preparations may be necessary. They also did a study on this guideline to see how it went. So there were 170 discharge prescriptions, 83.4% of which were compliant with the guidelines over a 2-year period. In the first year they had a really good uptake of the guideline, but over the next year it sort of decreased, and that might be something that we see at Austin as well. So ongoing sort of achieving compliance is always an issue for us to be aware of and looking into as well. Now our new guidelines have been distributed to the head of the surgical units, and they will be distributing it to the sort of interns to help them as well, and something that we can help them with prescribing in the future too. And that is all. Thank you. Any questions?
How you say with the pentothal there's a lower risk of misuse, abuse, potential.
Yeah.
Is that just because it's newer and we're not using as much? Is there like a pharmacological reason that it's less likely to?
They didn't sort of hypothesise why that was a result, but that's sort of what most of the studies were saying. Be as a result of pharmacological effects or, not using it as much.
When you were looking at the protocol for SHIELD over at Western Australia and what they do with their prescribing, was there any mention of work that was done after implementation of that protocol to see whether patients, when they were discharged from hospital, actually were maintaining pain relief?
No, they didn't look at that. The sort of main primary endpoints were uptake of the protocol itself and if the discharge scripts were in alignment with the protocol, not so much patient-centred.
Thanks, Olivia.